Women are suffering these days, especially between the age groups of 20 to 35 and 35 and above.
Yeah, ideally we should be dividing them between the age groups of 20 to 35 and then 35 and above. So when we were traditionally being taught, we were not thinking of many problems in the age group of 20 to 35. We thought that was the reproductive age group, and the women don't have many problems in that, except for maybe some menstrual pain or some premenstrual discomfort or something like that. But nowadays we have seen a real increase in polycystic ovarian disease, which is nothing but a simple hormonal imbalance. We all know that we have an estrogen and a progesterone hormone in the body, and in polycystic ovary the balance between these two hormones becomes haywire, and that can cause a multitude of problems like weight gain, irregular cycles, increase in the facial hair, loss of hair from the scalp, and some infertility related problems. So this PCOD has come up so much so that every third patient that we see in the OPD these days is suffering from polycystic ovary. It may be a mild to a severe variety, but it is there, and it may not be bothering them at that particular time, but eventually it does lead to problems. So it is better that whenever you are facing a weight gain which is not explainable, like you are not eating that much, and despite exercising you are gaining weight, or your cycles are becoming irregular or delayed, mostly delayed, and or the cycles are becoming scantier, and you are noticing that you are having a lot of acne on your face, facial hair growth is increasing, that is the time when you should be thinking of PCOD. And one most important thing that you should think about is whether in your family there is a history of diabetes. If anybody, be it your grandparents, uncles, first degree relatives, all included, if you have a family history of diabetes, you are more prone to have a PCOD in you. So if you are having a polycystic ovary, or you are suspected of having a polycystic ovary, the health checks that we do usually to diagnose are a variety of hormonal tests which are done particularly on the day 2 or 3 of the period. That means if you got your period today, you either do them tomorrow or day after, and you preferably go fasting by 6 to 8 hours to do the test. And those hormones will also include a thyroid hormone test, because thyroid hormone and polycystic ovary are quite closely related. A patient who has a polycystic ovary will eventually develop a hypothyroid, or she may be a borderline or a subclinical hypothyroidism. So at different age groups it may trouble you in a different way. When you are young, school going, you may have irregular cycles. When you reach your adolescence, you may start having pimples all over the face. When you reach a little more higher, then you may start having weight gains, and then when you get married, you may start having infertility problems. So this is when you should think. We should not think that okay, 3 cycles nahi aaye to koi problem nahi hai. We should start, diagnosing and be prepared for the test and go and seek a gynecology consultant. Then the second thing that is coming up very rapidly is what we call endometriosis. Endometriosis is a disease which we technically call as a non-cancerous cancer in the body. That means it spreads like cancer, but it is not a cancer. It recurs when you remove it. It has a hormonal dependence somewhere. It can be deep-rooted. It can start anywhere. You can have endometriosis even in your lungs, in your skin. But typical endometriosis is seen either in the uterus wall, where it is called adenomyosis, or in the ovaries, where they make major hemorrhage or blood-filled cysts, and which give you painful cycles. Real pain in the periods that will require analgesia more than the normal over-the-counter analgesics that we are. And endometriosis does give you infertility also. So anytime you are experiencing severe pain during periods or after periods, you are vomiting during your cycles, and the blood flow is excessive or even scanty, or you will have difficulty in urination or defecation during your cycles, pain during the process, that is a very high indicator of endometriosis. Unfortunately, endometriosis doesn't have specific tests. So we take the help of a clinical examination plus an ultrasound, which may or may not detect cysts. There may be no cysts and still you may be having endometriosis, and a tumor marker which we call CA-125, which is typically used to detect ovarian cancers. But this tumor marker is raised, not always, but most of the times when you are having endometriosis. So, and treatment may vary from simple over-the-counter hormonal pills to laparoscopic surgeries to extensive open surgeries to major thoracotomies to anything. And unfortunately, again, what I say, it's a recurrent disease. You remove it, it will come back. And third thing that is really coming up, because we are becoming more sexually aware and more sexually active society, which we were not maybe 10 years back, are the STDs. The sexually transmitted diseases are really on the high. So we are getting more HPV positive testings in younger females, and that HPV positive testing is again a precursor for cervical cancer in the future. So that is, and these all can be detected while you do a small gynae checkup, a speculum examination, and a pap smear. So, and for doing a pap smear or a gynae checkup, we always ask the patients to be prepared, not doing any douching, or typically should be done 2 to 3 days after you have finished your periods, and having no sexual intercourse on that day, and no douching for 2 days before you have your pap smear. That is the prerequisite of doing a pap smear. And now another category that falls into this 20 to 35, majorly 30 to 35 now, is the women who want to get pregnant. Now, all the patients who want to get pregnant ideally should have few basic tests before they plan a pregnancy. They should know simple tests like blood group. They should know whether they are an Rh positive blood group or not. There are many other complications which are related to having an Rh negative blood group if your partner is Rh positive. That means if your O negative partner is positive, you may have problems in pregnancy. So you should know them beforehand, so that you are prepared in that particular way. Thyroid disease is really coming up very, very commonly, especially in North India. About 60% of the patients these days are diagnosed with subclinical hypothyroidism, and on the thyroid hormone, the baby's mental growth is dependent. So we have enough evidence and data to prove that your baby's IQ is directly proportional to your thyroxine levels in the blood.
That is a great revelation.
So if you are a hypothyroid and you have not tested it, and the baby's maximum brain development will be in the first 3 months of pregnancy, the baby is going to have a little difference in the IQ than the normal thyroid patients. Third is the thalassemia detection. So if you are thalassemia minor, detected as thalassemia minor when you are doing a hemoglobin electrophoresis test, what we call, then we need to test your partner as well. If your partner is also thalassemia minor, you have a very high chance, a 50% chance of delivering a thalassemia major baby who will require blood transfusions throughout the life, and the life expectancy doesn't go beyond 17-18 years. Then there are other tests like rubella. Rubella infections are small infections like upper respiratory tract infections that all of us get in our childhood, and you get rubella only once in a lifetime. If you are rubella positive, you don't need to worry in the pregnancy. But if you are rubella negative and you get rubella in pregnancy, baby might have serious congenital malformations. So it is very imperative to diagnose these before you actually plan a pregnancy.
Any tests that can detect?
That's what I'm saying. Yeah, there is an IgG rubella test which we order. We order an HB electrophoresis for thalassemia. We order a blood group plane for detecting your blood group, and a thyroid profile for detecting the thyroid. These are the basic tests that we order before anybody goes for a pre-pregnancy detection. Now, if we go beyond 35, assuming that we have now conceived, delivered, had babies, whatever. Again, 35 and above, major problems will be because of polycystic ovary and endometriosis. But to add on it, one major thing that comes in female health is the fibroids and the ovarian cysts. These ovarian cysts may be benign or they may be malignant, but usually benign cysts do form in every woman's cycle. You do form small 2 cm, 3 cm cysts, and they go on their own. You don't actually need to do anything.
Right.
But if you are having a regular check, you will come to know by an ultrasound that you are having a persistent cyst or a growing cyst, which needs to be evaluated, which needs to be diagnosed, whether it is a benign, it's a cancerous, and the cyst more than 5 cm need to be operated.
Okay.
Again, fibroids. If they are there and not giving you problem, 30% of all women will have fibroids.
Okay.
They are there, not giving you problem, we don't bother much. But if they are more than 4 centimeters in diameter, they are giving you heavy periods, they are causing infertility or recurrent miscarriages, then they need to be dealt with. And the only way that you can get to know about these fibroids is by doing a routine checkup or an ultrasound, which if you are regular with your health checks, you can detect at a very early stage and not allow the cysts or the fibroids to grow bigger and give you trouble.